Good evening, everyone. The abstract that I have been given to discuss today is the randomized trial of afatinib with cetuximab versus afatinib alone for the first-line treatment of EGFR mutant non-small cell lung cancer. These are the final results from the SWOG S1403 study. So as we know, in most of the first generation EGFR TKIs, resistance develops between 9 to 12 months after treatment. And there are multiple strategies designed to overcome this resistance because of the identification of all the resistant pathways. We know that 50 to 60% of the resistance is because of T790M, and osimertinib is effective in this scenario. So this study is based on preclinical evidence of afatinib and cetuximab, which delayed resistance in mouse models, as well as evidence from a phase 1b study, which was conducted in patients with EGFR mutant NSCLC who had progressed on first-line EGFR TKIs. So the study design, this was initially designed as a phase 2 going to phase 3 trial, which was supposed to enroll 605 patients, and after a futility analysis progressed to phase 3 if the trial was not futile. However, due to poor accrual, they stopped it in the phase 2 phase and readjusted the sample size to the 178 patients, and the phase 2 endpoint as PFS. So here, adult patients with treatment-naive non-small cell lung cancers were included. They only included EGFR exon 19 deletions or L858R, and rare mutations were excluded. Patients with the performance status of 0 to 2 were included, and asymptomatic brain mets which did not require steroids were allowed to be enrolled in the study. So the patients were randomized 1:1 to either afatinib alone or cetuximab with afatinib, and cetuximab was given at the dose of 500 milligram per meter square every 2 weeks. So this is the consort diagram. Ultimately, 78 patients received the cetuximab plus afatinib combination, and 85 received afatinib alone, and these were included in the safety analysis. And 83 patients who were initially randomized to the set combination arm, and 85 in this afatinib alone arm were included for the primary analysis. So important things to note in the baseline characteristics: 2/3 of the patient had EGFR exon 19 deletions. Almost 95% were adenocarcinomas, and around 1/4 of the patient had brain metastasis. So the primary endpoint of this study was PFS. And this is the curve which is showing the progression-free survival in the arms, that is afatinib versus afatinib with cetuximab. As you can see, there has been no benefit of the addition of cetuximab in these patients, and the hazard ratio was 1.1, and this was not significant. This forest plot shows the effect or the impact of addition of cetuximab in various subgroups, and as you can see here, there is no benefit of adding the cetuximab to afatinib monotherapy. So secondary endpoints were response rate, overall survival, toxicity. So we'll go through them one by one. So again, this Kaplan-Meier curve shows the overall survival, which is nearly overlapping on both the arms. And there was no benefit, significant benefit noted with the addition of cetuximab to afatinib. The hazard ratio was 0.82 and a P of 0.44. And if you look at the subgroup analysis, just like the progression-free survival, the overall survival did not seem to benefit, the addition of cetuximab did not benefit in various subgroups, including EGFR mutation, PS, or other factors such as age and gender. Another important thing to note is that the addition of cetuximab did not improve the response rates in the study. In afatinib alone arm, it was 74%, whereas it was 67% in the combination arm. The time to response and the median duration of response was similar in both the arms. So this is additional data where it shows the PFS and OS based on the EGFR mutation, that is exon 19. There has been no difference in the arms in exon 19 deletion patients, as well as exon 21 L858R patients, where the addition of cetuximab to afatinib didn't seem to improve outcomes in this group as well. An important part of the study is the adverse events, and if you look at the adverse events, the incidence of grade 3 or higher adverse events was 72% in the combination arm versus 40% in the afatinib alone arm. So this you can see is grade 3, 4, and 5 adverse events in this afatinib plus cetuximab arm. And if you look at this, this is the grade 3 and 4 events in the afatinib alone arm, and this was significantly increased. Also, skin toxicities was significantly higher. You can see the dry skin, paronychia, acneiform rash, maculopapular rash. The incidence of grade 3 toxicities in these were significantly higher with the addition of cetuximab, which we know would have made a significant impact on the patient, also on quality of life. And you can see many places there have been no grade 3 incidence of paronychia with afatinib, but you can see here 5% of patients had grade 3 paronychia with the combination. Another thing to note were the treatment-related deaths and the dose reductions and discontinuations. There was one death related to treatment in the combination arm. There was a significant increase in dose reductions in the combination arm. You can see nearly 60% had a dose reduction. Either afatinib was decreased to 30 mg or to 20 mg, whereas in the single afatinib arm, that is afatinib alone arm, it was much lower. 30% discontinued cetuximab in the afatinib plus cetuximab arm. That is, out of 75 patients, 25 patients did not take cetuximab, and the median number of cycles taken were around 9. So to conclude, this study, where the combination of afatinib and cetuximab in newly diagnosed patients with EGFR mutated lung cancer showed no improvement in outcomes, increased toxicity, frequent dose reductions, and frequent treatment discontinuation. So my take on the study, there have been prior studies with the use of anti-EGFR drugs with the EGFR TKI, but this study has failed. The probable reasons would be the setting. This study was a in the first-line setting in treatment-naive patients. Prior studies used it in patients who had treatment failure and already probably had active resistance pathways, and the addition of the second drug, that is an anti-EGFR drug, would have worked better. Whether the strategy is right in a newly diagnosed patient, whether dual inhibition of EGFR without amplification, overexpression, or known resistant mutations will really improve outcomes, or whether it is better to target two different pathways to get a better benefit. And also the toxicities, dose reductions, and the treatment discontinuations would have probably led to a loss of benefit, if at all there was any, because of dilution and patient dropouts from the study. So with this, I end my talk. Thank you.
A very good evening to all of you. At the outset, let me thank the organizers for giving me the opportunity to present this paper.